Hello, my name is Brad King, and in this presentation I will be discussing several approaches to airway management in order to determine which preoxygenation practice safely and effectively prevents oxyhemoglobin desaturation during endotracheal intubation. I'll begin my discussion by talking about the indications regarding endotracheal intubation, as well as the most commonly reported complications associated with the procedure. Next, I will review the physiology and deliberate why preoxygenation is so vital to patient safety. Then, I will compare and contrast conventional preoxygenation to more advanced preoxygenation techniques. Finally, I'll demonstrate why BiPAP is superior in terms of preoxygenation and explain how it facilitates a hyperoxic state by reducing the occurrence of shunt physiology and increases the surface area of the alveolus. Acute respiratory failure is a fatal condition that frequently requires mechanical ventilation following endotracheal intubation. During intubation, critically ill patients are subject to severe complications, with hypoxemia being reported most frequently. Hypoxemia is defined as a decrease in the partial pressure of oxygen in arterial blood, or simply put, oxygen level is lower than usual. This is said to exist when the partial pressure of oxygen is less than 60 millimeters of mercury, or when the patient's oxygen saturation falls below 90%. This manifestation typically occurs secondary to a physiologic shunt, which means that the alveoli are being perfused, however, they are not being ventilated properly and not receiving any oxygen. When this is present, it leads to a direct mixing of deoxygenated venous blood into the arterial blood, resulting in hypoxemia. Shunt physiology can be caused by a number of disease processes, including pneumonia, atelectasis, which are collapsed alveoli, pulmonary edema, and acute respiratory distress syndrome. It's dangerous because no matter how much oxygen you administer to the patient exhibiting signs of shunt physiology, their oxygen level will likely never improve since inhaled gas never reaches circulation, which can result in serious complications such as dysrhythmias, hemodynamic decompensation or shock, hypoxic brain injury, or even worse, death. So in order to reduce this manifestation, clinicians attempt to administer high levels of supplemental oxygen prior to intubation to increase the concentration gradient in the alveoli, which subsequently increases the PaO2 and SaO2. Preoxygenation creates a hyperoxic state that extends the period of safe apnea and allows the clinician to safely insert an endotracheal tube without the patient crashing. Ultimately, the goal is to denitrogenate the residual capacity of the lung and increase the partial pressure of oxygen in the blood as high as possible to achieve an oxygen saturation of 100%. Next, I'm going to introduce you to Fick's law of diffusion. As you can see from the illustration, the oxygen diffusion rate of gas across the alveolar capillary membrane is directly proportional to the concentration gradient, the surface area of the alveoli, and inversely proportional to the thickness of the membrane. Therefore, in order to increase oxygenation, three things must occur. First, the oxygen level inside the alveoli must be higher than the oxygen level in the bloodstream in order to create a concentration gradient from high to low pressure. Second, the alveoli must be accessible in order for oxygen to reach the alveoli and diffuse into the bloodstream. Third, there cannot be anything between the alveoli and the capillary that will slow down the diffusion rate. An example of such barrier would be fluid or pneumonia. This creates a thick barricade and inhibits oxygen from diffusing into the blood. This will lead to impaired gas exchange and hypoxemia. So now that you've been introduced to the concept of preoxygenation and the hazards associated with hypoxemia, we're now going to talk about the different preoxygenation techniques. The standard preoxygenation technique utilizes a non-rebreather mask applied directly to the patient's face. This method produces a fraction of inspired oxygen around 60 to 80%. When this technique is employed, the patient is placed in the upright semi-Fowler's position and instructed to take 8 deep breaths or allowed to breathe spontaneously for 3 minutes. The next approach is a little more aggressive. This advanced practice involves placing a patient on a BiPAP machine similar to the ones utilized for obstructive sleep apnea. This device produces a fraction of inspired oxygen of 100% through a mask placed directly on the patient's face. Similar to standard preoxygenation practice, the patient is placed in the upright position and instructed to take 8 deep breaths or allowed to breathe spontaneously for 3 minutes. This method assists the patient's spontaneous effort by providing 2 levels of positive airway pressure. This is especially significant for patients exhibiting signs of shunt physiology, since the positive pressure will increase the size of the alveoli and reduce the barrier thickness, allowing improved gas exchange and increased oxygenation. Following the 3-minute mark, the mask is then removed and the patient is intubated. So as I mentioned before, I wanted to determine which method provides superior preoxygenation before intubation and reduces the occurrence of hypoxemia. Well, following a review of the literature, I concluded that the application of BiPAP is superior in terms of oxygenation compared to standard preoxygenation practice. In a study conducted by Baylor and colleagues, they examined the effect of BiPAP on critically ill patients that required intubation. At the end of the preoxygenation period, patients receiving BiPAP had a mean SpO2 reading of 98%, where those receiving standard preoxygenation therapy had a mean reading of only 93%. Of the patients in the BiPAP group, 6 of the 26 participants were unable to improve their low saturations with high FiO2 alone, and it wasn't until BiPAP was initiated that their oxygen saturation increased. Likewise, in a study conducted by Antonell and colleagues, of the 26 patients being intubated, 13 received standard preoxygenation and 13 received preoxygenation with BiPAP. Their team concluded that BiPAP was superior in terms of preventing hypoxemia during intubation.